Now, there are two other fusions we'll talk about very quickly. NTRK fusions, which are pretty rare, seen in less than 1% of tumors. Again, this is also one that is better detected with RNA testing. We have two drugs approved, larotrectinib in 2018, entrectinib in 2019. And if that sounds familiar, Dr. Nagasaka presented this for ROS1. Both of them are oral drugs, work very well. Larotrectinib, a response rate of 79%, entrectinib 61%. Again, the responses are quick. For entrectinib, less than a month, the median time to response. They're durable. And when we see these waterfall plots, they really work across different tumors, not just for lung cancer. Here, larotrectinib, here, entrectinib. Very effective, potent medicines, and they work well in the brain. These data are for entrectinib. But these drugs do have important side effects. So we can see, as with most of these drugs, rise in liver tests, fatigue, nausea. We can see both with larotrectinib and with entrectinib. But when we think of side effects for these agents, the big difference between this and something like a RET inhibitor is that these are on-target effects, which means if you have a really well-designed specific NTRK inhibitor, you're still going to have these side effects because these are the result of blocking NTRK. While the tumor is using NTRK to survive, NTRK still plays a role in our normal function. So when we block that, there's a price to that. For example, we block TRK. TRK is responsible for sensation. And when we block that, and TRK also for sensation, proprioception, the sensation of where we are in space. And so when we raise our foot, we know that it's raised because of the sense of proprioception. If we block TRK, the tumor responds, the tumor can't survive, but our sensation is altered as a result of that. And we have trouble with proprioception, which alters the way we walk, which manifests as things like dizziness or unsteady walking. TRK-B is responsible for appetite. And so when we block that, our appetite starts to go way up. And so we see weight gain, but it's not water weight or retaining fluid. It's from hyperphagia, from eating. And so when we see weight gain, again, this is something that occurs more and more over time. And it's not a small amount of weight gain. Some patients can gain, 10, 20, 50. We saw one almost 100 pounds weight gain. So there can be a quite significant amount of weight gain, and it's the result of blocking NTRK. And there are medicines we can use now, shown on the right, like GLP analogs, topiramate, silbutramine, medicines that our rheumatologists and endocrine physicians are really using for other purposes that can be effective here. But this also responds to dose reduction. Dizziness, seen with a lot of NTRK inhibitors. And when you think of lightheadedness, vertigo, dizziness, imbalance, they're probably all describing the same thing. And this is the result of NTRK inhibition. And when we see this, it means we're given too high of a dose. And you have to lower the dose, and that way patients can stay on treatment. Now, withdrawal pain is a very interesting one. This is one in the phase 1 study, in the early studies of this drug. When we first saw this, we didn't know what was happening. But this is basically because NTRK plays a role in our sensation of pain. So when we block NTRK inhibition, the body increases the amount of pain receptors. And overall, it just evens out. But then when you stop an NTRK inhibitor, you can have these diffuse body aches as a result of this withdrawal. And then if you take a dose of the NTRK inhibitor again, pain immediately goes away, like within a couple hours. It's a very interesting physiology. And so if a medicine is no longer being used and we're stopping it, we usually kind of taper it down a little, and you got to make sure you have a supply of pain medicines to get through it. It will pass. It's not a permanent effect, but it's a very unique side effect. So when we stop these NTRK inhibitors or any drug that blocks NTRK, you can sometimes see this withdrawal pain syndrome, which can be very serious. There are new drugs. We heard about repotrectinib from Dr. Nagasaka. This is also being used for NTRK tumors and looks very active after prior inhibitors, though not yet FDA approved. It does have fast track designation, but these side effects for NTRK are the important thing to watch for.